Rheumatic fever. We are going to discuss about rheumatic fever. Rheumatic fever is caused by this is a systemic disease of childhood, often recurrent, that follows group A beta hemolytic streptococcal infection. It is delayed non-suppurative sequelae to URTA, upper respiratory tract infection, with GABS streptococci. That is beta hemolytic streptococci, group A beta hemolytic streptococci. It is a diffuse inflammatory disease of the connective tissue, primarily involved in heart, blood vessels, joints, subcutaneous tissue, and CNS. Epidemiology: in 5 to 15 years are the most susceptible age group, rare in children less than 3 years. Girls are more affected than boys, common in third world countries. Environmental factors include overcrowding, poor sanitation, poverty, incidence more during fall, winter, early spring, etc. Pathogenesis: delayed immune response to infection with group A beta hemolytic streptococci. After a latent period of 1 to 3 weeks, the antibody-induced immunological damage occurs in heart valve, joint, subcutaneous tissue, and basal ganglia of the brain. Group of beta hemolytic streptococci strains produce rheumatic fever. M types include 1, 3, 5, 6, 18, and 24. It occurs pharyngitis, that is, it is produced by group A beta streptococcus that leads to acute rheumatic fever, rheumatic heart disease, and post-streptococcus glomerulonephritis. Skin infection produced by group A beta hemolytic streptococci led to post-streptococcal glomerulonephritis only. It will not result in rheumatic fever or carditis. Clinical features: arthritis. Arthritis include migratory polyarthritis involving major joints, commonly involved joints knee, ankle, elbow, wrist. Occurs in 80%. Involved joints are extremely tender. In children below 5 years, arthritis usually mild, but carditis are more prominent. Arthritis do not progress to chronic disease. Clinical features: we have explained about arthritis. Now carditis. Carditis is manifested as pancarditis or endocarditis, myocarditis, pericarditis. Occur in 40 to 50% of the cases. Carditis is the only manifestation of rheumatic fever that leaves sequelae and permanent damage to the organ. Valvulitis occurs in acute phase. Chronic phase: fibrosis, calcification, stenosis of the heart valve. Clinical features: chorea, symptom chorea. It occurs in 5 to 10%, mainly in girls of 1 to 15 years of age. May appear even 6 months after attack of rheumatic fever. Clinically manifest as clumsiness, deterioration of handwriting, emotional ability, grimacing of the face. Now, erythema marginata. It occurs in less than 5%. It is a unique transient lesions of 1 to 2 inches in size. Pale central with a red irregular margin, more on trunks, limbs, and non-itchy. Worsen with application of heat, often associated with chronic carditis. Subcutaneous nodules, often in 10%. It is painless, pea-sized palpable nodules. Mainly occur in overextension surface of joints, spine, scapulae, and scalp. Associated with strong seropositivity, always associated with severe carditis. Other features are minor features include fever, low-grade fever, arthralgia, pallor, anorexia, loss of weight. Laboratory findings: we can see high ASR, anemia, leukocytosis, elevated C-reactive protein, ASO titer greater than 200, peak value attained at 3 weeks, then come down to normal by 6 weeks. Anti-DNase B test, throat culture. ECG, prolonged PR interval, we can see echo, valve edema, mitral regurgitation, left atrium and left ventricular dilatation, pericardial effusion, decreased contractibility. Diagnosis: rheumatic fever is a mainly clinical diagnosis. No single diagnostic sign or specific laboratory test available for the diagnosis. Diagnosis based on the modified Jones criteria. Modified Jones criteria include carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. These are the major criteria. Minor criteria include previous rheumatic fever or rheumatic heart disease or arthralgia fever. Laboratory: acute phase reactants, erythrocyte sedimentation rate, C-reactive protein, leukocytosis, prolonged P interval. And supporting evidence include increased titer of anti-streptococcal antibody, positive throat culture for group A beta hemolytic streptococcus, and scarlet fever. In the presence of two major criteria or one major criteria plus two minor criteria indicates high probability of acute rheumatic fever. Treatment includes: step 1 is primary prevention, that is eradication of streptococci. Step 2 include anti-inflammatory treatment, that is aspirin and steroids. Step 3, supportive management and management of complication. Step 4, secondary prevention, that is prevention of recurrent attacks. Step 1, primary prevention of rheumatic fever, that is treatment of streptococcal tonsillopharyngitis. We can prevent this by benzathine penicillin 6 lakh unit for patient AM once less than 27 kg and 12 lakh for greater than 27 kg. Penicillin B, penicillin G is penicillin B, we can use penicillin B children 250 mg 2 to 3 times a day, or adolescent 2 to 3 times a day, 500 mg. And it's allergic to penicillin, we can use erythromycin 20 to 40 mg per kg per day. Thiasuccinate. Anti-inflammatory treatment: arthritis only aspirin 75 to 100 mg per kg per day. Give us 4 divided doses for 6 weeks. Carditis, we can give prednisolone 2 to 2.5 mg per kg. Give us 2 divided doses for 2 weeks. Step 3, supportive management include address treatment of congestive cardiac failure, retaliation. We can use retaliation diuretics for this. Treatment of chorea with diazepam or haloperidol. Rest to joints and supportive splinting. Step 4, secondary prevention of rheumatic fever or prevention of recurrent attacks by benzathine penicillin 12 lakh unit every 4 hours IM or penicillin V 250 mg twice daily, sulfadiazine 0.5 gram once daily for 75 kg with patient with 75 kg. If more than 75 kg, we administer 1 gram sulfadiazine. Allergic to penicillin and sulfadiazine, we administer erythromycin 250 mg twice orally. Prognosis: if not on prophylactic medication, it can recur. Good prognosis if in an older age group, no carditis in the initial attack. Bad prognosis in younger children with carditis with valvular lesions. So let's finish the topic. Thank you.